Okay, so you all got that, right? But this is like really like a hardcore exposure. But as I said, sometimes you really need to be thinking about what you're trying to do. You can either be doing exposures like with phobias and with separation anxiety, but sometimes, especially with the social anxiety, it's not just standing there in a social situation, it's actually having to do something. And so I want to make that point where they may have to like do something, and then you come back and say, okay, so you gave that 5-minute presentation in class. You did it. Let's talk about how it went. And, and then we're going to get into the cognitive processing after. But I just want to make the point that, sometimes it's really like, yesterday I think John Weiss was showing them holding something, But even then, that person was actually talking about it. Right? Do you remember that? They were the jam. Yeah. But yeah, wasn't she talking like through it though?
Yeah, it was
yeah, I know.
Like she felt like
okay, whatever. But sometimes you just have them hold things and touch it. But sometimes, and you can just. I personally would rather they stay there and just hold it and not do anything, and then only afterwards talk about it and process it, because otherwise it can be distracting. So I prefer the processing after the exposure. But. I wouldn't want to say that anything is carved in stone, because we don't really have hardcore research on how all this stuff is working. But I just don't think it's good to be distracting yourself while you're doing it. I think it's good to just say, okay, just rub it, and just rub it. Okay, what's your rating now? 5. Okay, well, keep rubbing it. Let another couple of minutes. What's your rating now? So that's how I would do it. And also, again, I would usually ask ahead of time, how many minutes are you willing to stick with this? How many minutes? Okay, I'm going to bring out this, was it jelly? Is that what it was? Oh, it's supposed to be blood? Okay.
there was no blood in a little.
There was processing with the blood video, and there was no processing in the one with
Oh, okay. Oh, okay. All right. I guess I was still excited because I knew John Piacentini. He's a guy at UCLA who looked really good back then. No, that was an old tape. I mean, it was he still looks good, but he still looks good. But that was an old tape of John. I've known John for a long time. So anyway, yeah. But I usually ask how many minutes they're willing to do it. And then make an agreement, because that also helps. Because sometimes they say, well, how long do I have to do it for? And then we say, well, how long do you want to do it for? And then they go, and usually I would try to get them to do it for as long. If I would say, well, what about 10 minutes, knowing that that's a lot? And then they say, oh, I don't think I can do 10. And then I said, well, then what do you think? And they go, okay, 5. I said, 5? You want to try 7? Sort of like, let's make a deal. You want to try 7? Okay, well, I'll do 6. So we kind of like negotiate, because you want to get them to do as much as possible, and not to chicken out.
I have a quick question. When you are,
I'm gonna get this down today with the mic.
when you're working with a child, and you're talking about coaching, there with the child and processing with the child. What about in situations where the child needs to go to the school and try the experiment at school, but you're not there with the child? In your experience, what works best? Doing it with the child, the experiment, or having the child do it by himself?
So, as I've said, the sessions, like you'll see in the manual, it gets to be, as you go after the first 2-3 manuals, and by the way, my manuals I know are very simple looking, because they're not like, I don't sell them or anything. So these are just meant for me and my students. That's why they don't have nice pictures. And I mean, they're pretty simple, amateur-looking things. So I want to apologize, because some of if you're expecting fancy, smashy manuals. But don't judge a book by its cover, right? But anyway, if you look at the manual, the beginning, it has a lot of stuff in it. But as you go further on, it's basically talk about what happened in between session with the exposures, talk about what happened, process it, and then do another one. So to answer your question, basically what we would be doing is, we would practice things in the session, and then we'd say, okay, now let's think what you're going to do between now and next week out of session. And it would be a similar type of thing, and then we might role play it in the session, and then they go and do it next week, and then they come back and we say, how did it go?
In terms of processing during the exposure, what do you think about, like, I understand the idea that if you distract, then it's not, then the exposure isn't as anxiety provoking, and the whole idea is that they, really experience that. But what about, like, during the exposure, like just talking about, like with the jam example, like how sticky does it feel, and, like almost talking about sort of, like trying to really get into what they're feeling as they're doing that.
I mean, a lot of it's not really to get into their feeling. Like, I would like to wait because I do have the thinking things that the kids are doing because that's what you process the possible distorted thinking, but afterwards, okay. But I would prefer to do it
after the exposure.
I mean, again, there's no right or wrong to this. I prefer not to talk during the exposure. I prefer that they do it. And then afterwards, okay, we're going to do this for 10 minutes, and then, all right, we just did this. Let's talk about what happened. Let's talk about your experience. That's my clinical preference, because I don't want them to get distracted, and talking will distract them. Okay. In fact, it's very interesting. Like there's some really interesting research, for example. It hasn't been with children, but it's been with adults. But it's interesting. That sometimes exposures that are, and again, this is with adults patients, that adults with GAD sometimes don't do as well in exposure therapies, sometimes because their worrying is distracting them from the exposures. So, that's why some people say you need to do not just exposures, especially with GAD, but the more cognitive, because, you can be doing an exposure with them, but they're still, they're not even engaged in the exposure. They're just in their own worry world. So, so that's why I say the less you can do to distract is better. Yeah.
So you really have. You have me think. You really have me thinking about this extinction thing. Because yesterday you showed the curves, the distress curves, and they always go down in the end. And it would seem to me that something that would be really important is when you expose the kid, you wouldn't want the kid to escape the exposure while they were still upset.
Right.
So if we contract for 7 minutes, at the end of 7 minutes, the kid's still really hyped.
Right.
What do you do, and how do you gauge that?
No, I mean, that's a really good question. I guess we try to get them to stay there as long as possible, but we also don't want to torture kids. And we also have an ethical responsibility not to put them in something that they cannot handle. So, so that's why when we put them in any situation, it's not so intense that they're going to freak out. So it's something that's provoking anxiety, but not so much that they're going to have a breakdown, so that when it is over, it's over. Because I'm not going to lie. I do remember one time we had. I can count on less than one hand when I remember we had one teenage girl with social anxiety, and typically with the social anxious kids, we often, again, it's the core fear, but sometimes we do have them make little talk about themselves in front of a few of the undergraduates. And I remember we had this one girl, and she ran out of the room, ran out, just ran out of the building. Sort of like what some of you guys see with the school refusal kids. They just ran out of the building, and we could never get her back. That was too hard an exposure, and it shouldn't have happened.
So you really have to titrate it right.
Exactly. In fact, I would like to show you, I'm going to come back to all these slides, but I realize I think my last two slides are probably, I want to put these slides, this is the last two slides, but I think it's a good way to frame the whole thing. In terms of the big picture, I think to optimize gains, these are the really important points to be made. Assessing and targeting the core fear that we talked about. Directed discovery, which is not you, and we're going to go over this, but it's not after you do an exposure that you say to the child, so you see, they didn't laugh at you. That's not directed discovery. Directed discovery is, so what did you learn from this? So what do you think that means? So what does it mean in terms of how you used to think about things? And what does it mean for the next time you're in a situation like that? When do you think what just happened may not happen again? What might make that not happen? So that's this, directed discovery, not you, because it is, well, that's important. Involvement, we already talked about the children, the therapeutic alliance. Trust, very important. We already talked about cooperation, collaboration, and we're going to talk about relapse prevention at the end. And then working for generalization, which we'll also talk about, but it's but you already can get the picture of what that means, that you don't just focus on one thing, it's generalizing. And then obviously any good therapy situation, you arrange for termination. And individualizing the program. A lot of people, there's so much misconception about exposure and CBT and evidence-based treatments and the whole manualized approach to things. What I say to my students, actually they always think this is funny, I always say to them, every child is a snowflake. And I do believe that. Every child is a snowflake, and every child with any problem is a snowflake. I mean, of course, a child with, of course, there are more similarities with some children and others, but basically everybody's different. And you might have a general way of thinking about a program, but they're different. And so you do need to individualize and not just put people into a stereotype and not just use a manual and use the same hierarchy for everybody. It won't work. Well, it might work, but it shouldn't work. I don't think it will work. Okay, so this is optimizing gains. And then flexibility. Okay, we talked about this. And we said this yesterday. I'm not a manualized session by session person. As long as you get, I'm really hoping by after these 2 days, you get the general concepts and principles, and then you can do it. Okay, now interfering with gains. I think this is important. I think especially beginning therapists tend to do this, especially with CBT. It's like, okay, it's the opposite of doing self-discovery. It's you kind of like, okay, so you see how, and you explain the whole spiel to them, and teaching and preaching, and that's really not what, if any of you have ever been in a therapy session, it feels good when you're the one talking, as opposed to the other way around, where they're telling you what you think and what you feel. I mean, usually you go to a therapist because you're so upset about people telling you how you should think and feel. And the last thing in the world you need is for someone to tell you how you think and feel. It's like, don't tell me how I think, don't tell me how I feel. That's not what I need. I need to figure out what I think and what I feel. So I think an effective therapist is someone who is not teaching and preaching, but helping you, saying few words like, so what did you learn? So what does that mean? What else does it mean? And kids can do this. I'm not saying all kids, but a lot of kids can do this. It may not be in the same fancy, smanchy ways that we talk, but they can process this. It has to come from here. It has to come from here. I mean, I really believe that. I really believe that change comes from here, and it's not something that you can pull out with a fishing rod. And that's the same with this. Well, so what do you think it means? Well, come on, you must have some idea what it means, how you feel. Well, what do you well, come on. It just means, and again, that's just part of good child work, that you learn how to get kids to feel comfortable, and as they get more and more comfortable, they're able to share and open up, and sometimes it takes time, and I have to say, I mean, I always remember one child a long time ago, and this adolescent boy, and actually, sometimes I actually and I don't do as much of the work myself. I usually now supervise, but sometimes, occasionally, I do it myself. I mean, to be honest, I have so many cases, I have to supervise all of them. But I remember one child that I did personally treat myself, and in my clinic at the center at FIU, and he was refusing. He was an adolescent at one of the big high schools. If you'd name me the big high school, what's the? No, I think, yeah, and it was a long time ago, so yeah, it was at Braddock. It was like 1,500 kids in that school or something? 3,000, yeah, it was Braddock. Is that the biggest? It's 5,000, right? Yeah, is that the biggest school, right? And it's down south, right? Yeah, so he went to Braddock, 5,000 kids. Yeah. And he kept saying it was because of the school, it was too big, and da-da-da. And he did not want to come to FIU at all. He did, at least that's what they kept saying. Nevertheless, he kept coming every week, even though he didn't want to come. And I always say, well, if they come, then that tells you something, because if they really don't want to come, they don't come, especially if And he kept coming, and the point I wanted to make is that he was totally a non-compliant kid. He thought everything we were doing was stupid. But you know what? By the end of the program, he didn't end up going back to school. He ended up getting a GED. But you know what? The mother, and I still every now and then get notes from her, felt that this was the most successful thing in the world for him. Why? Because he was at least able to understand at the end that he had a social anxiety problem. He didn't want to deal with it because he figured out he can get a GED, and he figured out he can get a college degree by going online these days, and that he didn't need to face his fears. But he understood that he had this problem, and that maybe one day when it really interferes in his life, he will get some help for it. But at the moment and at the point that he was at in his life, he was just fine with not going back to Braddock, and getting a GED and getting a bachelor's online. But he eventually, over the 14 sessions, at least was able, and now in my research was data, that would be a failure. Because he still had a diagnosis, he still had anxiety, he still was not going back to school. But you know what? I share my failure with you because I actually think that was a success. Even though on all the indices of change, he was a failure. But you know what? He learned something. So there is self-discovery to this. And you could say, well, but yeah, maybe eventually, at least he understands that there's something out there that could help him if he wants to get the help. And I didn't I never forced him because I kept, there was only so much you could do with someone like him. Okay, who's in charge of the mic? Okay, good. Because we're going to cure me of my anxiety of the mic today. Yeah.
Maybe it was the mediator, the parent, who finally also understood, who kept sending you notes. So when she calmed down and understood,
well, the mother really was not that involved with this child. I mean, he was, a very independent, adolescent boy. So the mother didn't really play. I mean, yeah.
So the impairment was not there anymore for finishing school, but the impairment was there for social anxiety.
Yeah, I mean, well,
interpersonal.
I mean, he didn't really have that much. I mean, he had impairment, but not really, because that's the interesting thing about how you could have many problems these days and function okay. I mean, you could have social anxiety, and I mean, especially now with everything online, So, yeah. And social which is another issue, the whole social networking stuff. Yeah.
Well, that was one of the things I wanted to share. I don't know how many of you work with adolescents or whatever, but I have found, especially with male adolescents, at least the ones I've seen that maybe have a harder time verbalizing feelings. If I tell them, well, if you make believe that you were going to put a post on Facebook about this, the experience, the feeling, the whatever, they're able to do that really well. So where they might not be answering like how they feel or after an exposure, but like if you were going to text a friend or if you were going to post on Facebook, what would you do? And they can answer like that. So that is kind of
It is interesting. I mean, it's going to be really interesting how the next generation grows up with all this like social networking. It's really, I mean, it's yeah, you know, and how like a lot of, I mean, we have one boy who we just finished with who, you know, it was really a challenge because he was never leaving his room, but he was in his own world with the computer, with his own world, and we were trying to get some limitation of his computer time and having him go out to do face-to-face interactions, you know, but you know, we were not that successful. But then, you know, it's an empirical question down the road whether or not, what are the differences in functioning when your whole social world is through the computer versus face-to-face. I don't think we know. I mean, it's going to be the research questions of the future to like track kids who end up having just interact, because there are kids who have only interactions on the computer now. You know. I mean, a lot of people say my child's in my. A friend of mine says my daughter's always in her cave, and I said, "What's the cave?" "Oh, the cave, her room with the computer. That's all she is. She's in the cave." And a lot of people are like that, and you know, it's really. As a graduate student in the back, Katie, it's a good research study for you. You know.
No, and another technique with technology for an adolescent especially, and I'm thinking adolescent male that doesn't want to talk about his feelings, isn't comfortable talking about his feelings, you could assign homework in between sessions. Why don't you find a YouTube video that shows me how you're feeling?
Right.
Come back and just show me something that you found on YouTube that shows me what's going on with you. And we'll just look at it together.
Yeah,
You
yeah.
don't have to talk.
Right, exactly. And okay, but let's have one more question, then we'll move on. Yeah.
Unrelated, I don't know if you want to go there, because we've been talking so much about school phobia. But I had a very challenging case about a very small child. He's only 3, who was very afraid of going potty, of soiling. So he would hold it in for extended hours, and that was causing other collateral medical problems. So the reason why I had it and I didn't continue is because mom is trying to rule out a medical problem with the intestines, you know, stuff like that. But how do you handle processing and how do you handle exposure with such a small child, pre-verbal, really, you know?
I mean, there are ways, but I think, you know, if we start getting into analyzing every case, we won't. Can we maybe? I mean, if you.
I can see you later.
Yeah, I mean, I mean, but you know, I would set it up as a series of small behavioral tasks as well, and do reinforcement for a small child. I mean, that's how I would do it. I would just make it more behavioral and reinforcement. But you know, breaking it down, I have to talk to you. But we have treated a lot of kids with, you know, a lot of the kids with social anxiety. They don't want to go into the bathrooms, and so they are and so what happens is they then start having an anxiety about having a bowel movement during the day, because some of them, they get to school in the morning and they have to go and they're refusing to go into the bathroom, and then the anxiety starts to being having a bowel movement. So you know, and then what's the exposure? Yesterday it was vomit and now it's this, right? So we're going from the vomit to the shit. Okay, so and so what we do is we work out a schedule. You know, we have to do some exposures relating to the bathroom. I know, right? I know. You wouldn't blame them, right? You're saying you don't blame them, right? Yeah. Okay. Anyway, Okay, excessive focus on tasks. And I think that's really important, because even though what we've been doing is spending all this time speaking about doing exposures, you know, it's at the end of the day, this is about the child. It's not about the exposures. And again, the beginning therapists tend to get so focused. You know, that's why I don't like training people by a manual, because they get so focused on the manual and the task, and that they do this, that they do that. It's about the child. And how did you do? What did you think? How do you feel? It's not, well, did you do the task like this and like that? Okay, so you know, that's an important point clinically. Okay, and we're going to talk about the cognitive stuff soon, but again, I think this is a good overview, a good preview. You know, when people talk about cognitive restructuring and all that stuff, I do believe, I hate to sound so negative, but I do believe that sometimes when implemented incorrectly, what it ends up looking like cognitive therapy when done by inexperienced people, it ends up looking like teaching a parrot. You know, like the child is like the parrot. It's like, okay, so you can, you know, so can somebody give me an example? What? I mean, you know, what does that mean? So if I say to you, so what do you think about that? So doesn't it mean that people are not laughing at you? Doesn't it mean that people are not laughing at you? Doesn't it mean that you think people are laughing at you, but they're not laughing at you? So what do you think it means?
What does it mean? Think people are laughing at me? People are not laughing at me?
Yeah. So doesn't it like? Yeah.
It's like you already telling me.
Yeah, I'm telling you, and then you're telling me, oh, so people are not laughing at me. Yeah. So it means, so this taught you this past week that people didn't laugh at you. So that means that people are not laughing at you. So what do you think it means?
People are not laughing.
Yeah, exactly. So I'm saying that's an example of bad implementation, you know, and I shouldn't say bad. That's, you know, we're going to edit this. We already decided that this whole taping thing is not going to work, and I'm going to redo this whole thing in a really boring way, you know, at FIU, sitting there in a boring way, you know, blah blah blah. And my poor students are going to have to sit there, and although it's going to be very hard for me to do this in a boring way, but I'm going to have to try. But anyway, yeah, it's not bad, but it's inexperienced. You know, it's like. But it's an experience, an inexperienced person, and that's not what this is. It's not teaching kids to be a parrot and to have a mechanical thing. It has to be from here, and it has to be blended with the thought and the feelings, you know. Because let's face it, all of us. Let's face it, all of us. We all have our things, right? Right? Everybody here has something, right? I mean, and if you say no, then that's your thing. Right? If you say, no, I don't have my thing, well, then I say, well, that's your thing, okay? Because everybody's got their thing. So we all have our thing, and we all know that people many times have told us about our thing, or, you know, our shtick, or our whatever we want to call it. We all have it. We all have it. But how many times, you know, but does it eventually ever change? No, somehow if you decided to, you decided on your own. Okay, you know what? Maybe this is not a good thing that I'm doing. Maybe this is insensitive, or maybe this is rude, or maybe this is not. Well, some people never change, and they've been told many times. That's my point. My point is, you know, change has to come from within at the end of the day, and people have to understand it cognitively, emotionally, and then act on it behaviorally. And so that's my point. That's why if you say to someone, but they're not laughing at you, you see they're not laughing at you, and they go, yeah, they're not laughing at you, that doesn't mean.
You got it.
Yeah, that's why, again, I do believe in exposure, because I think the more they do it, the more they get the evidence, the more likely it is that they finally can accept it as true.
Can you comment, please, on the difference between conducting the exposures? I gather that in your lab, that you frequently accompany the children when they begin the exposure process. We work in an outpatient clinic where we would be able to do some simple exposures in an office environment, but our therapists would often not be able to go out, for example, into the world with children. So I think a challenge is, as I understand it, what you're hoping for is an exposure at a tolerable level for a child, so that you can create a condition, ensure a condition of relative safety for
And
the
success.
child. And success.
Yeah, and then they can continue.
So my question is,
It's a good question.
how could you adapt your procedure in an outpatient environment when often the exposure could be away from the therapist?
Yeah. I mean, that's a great question. I mean, as I said, we do, we never take the kids off campus, but we do take them off. I mean, we never take them off campus, so we do. So when we do things out of the office, it might mean going to the university cafeteria, going to the university library, going to the university health clinic, having them, getting a bunch of students and having them do things in front of students. But sometimes, I guess one answer is again, every child is a snowflake and every case is a snowflake, but whether or not it's possible for you to create simulations in the office setting, and even if it's like, maybe there are a couple of colleagues that they can talk in front of kids, for example. If it's separation anxiety, if you can have the mom leave the office setting and not have the child not having the child and the mom together the whole time. You have to give me some specific examples, and then I would have to try to use my, trying to be creative about it. I mean, do you have some specific examples in mind?
Well, I was just thinking
Yep.
about...
Yeah, but that's the answer. The answer is to try as much as possible to do it, simulate it and create it. Now, I'll talk about imaginal in a minute then, but let's just finish this. Wimpy exposures and way too scary exposures, okay? That's the other thing, okay, that we talked about. We don't want to be wimpy, and you also don't want to, scare the heck out of them. And we actually published a paper that showed that depression can interfere with this, and again, a lot of times the depression is secondary. We treat kids with depression, and we treat kids with ADHD, we treat kids with all these problems, but unfortunately we can work sometimes with the kids with depression, but the problem with them is that they're so inactive that it's hard for them to do anything and to get engaged. So if the depression starts being way interfering, it can affect the success of these programs. Again, that's all the more reason why it's important to treat anxiety early, because the more you wait with child anxiety, the higher the chances that they will, as they get into adolescence, become depressed. I mean, that's just the sequence of the psychopathology. So, okay. And then conflictual relations as well. But we'll talk about working with parents. So, because sometimes the anxiety of the child is maintaining. Sometimes the anxiety of the child is, is a way to keep is a way. They know that it really upsets the parent, and they're going to keep it going because they know it upsets the parent. So that's where getting parent involvement and doing parent-child stuff can be helpful. Okay, so again, these were my last. I was going to end with these slides, as conclusions, but I thought in retrospect it's actually good to put them up and be more at this juncture. Okay, but let me just go to the imaginal exposure for a second. Okay, so sometimes also, you try to do things in the office, but sometimes people do imaginal exposures where they do it in their heads, and I told you this yesterday. I personally try not to do imaginal. I try as much as I can to create things because, even like I told you this yesterday, the internet, the computer, there's a lot of exposure stuff you could do with getting information and presenting information that's incompatible with their anxiety. I talked about doing the survey. So I really try, I spend a lot of time with my students trying to be creative and thinking of real life in vivo experiments or exposures. The reason is because, I find it challenging sometimes to determine if imagery can be used. because we're basically asking a child to imagine something in their head, and you're hoping that I'm closing my eyes because that's what they need to do, and you're hoping that that imagery is going to elicit a level of arousal that will be scary for them, and that they're going to process that. And it's workable, it's doable, people do it, but I guess I am an empiricist and I can't see it. So since I can't see it, I don't know exactly what's happening. But again, it can work, but first you need to do it. And so you could have them close their eyes, and you can have them think about something, and maybe have them describe sitting of their room, and you have them close their eyes, and you say, okay, tell me about your room, and I'm closing my eyes because that's the only way you can do imagery. You have to close your eyes. So I can't even talk about imagery without closing my eyes. So anyway, and then you have them think about their room, and they go, well, I've got a gold curtain, and I've got 2 pictures on the wall, and then you say, well, what do the pictures look like? Oh, I have a picture of a dog, and next to it is a picture of the cat. Oh, and then you ask them to rate. Well, how clear do you see that? How vivid, how clear, and you have them to rate it. I mean, you have to make sure if they can really get it, and you have to ask them to give you all the details. So, what does it look like? What color is the dog? What color are your walls? You have to ask those questions, and then sometimes you have to train them to think about it. And the way you train them is how I just said. You say, well, tell me more specifically. What is the color? All right, and what color? What does your floor look like? Oh, it's brown. Is it brown wood? Is it brown carpet? And you kind of do that kind of very detailed probing, and then we're going to talk about how you construct hierarchies. But then you create hierarchies just like you would if you're doing in vivos, and then you just do like you're doing a regular exposure. But I don't know if that helps you. I don't. But that's basically this is how you do exposures in imagination. You're just having them. So you would say, and we're going to practice it when we do some exposures. But it's basically doing in vivo, but you're doing it in the child's head. Okay. So now what we're going to do now, and we're going to spend probably until lunchtime, we're going to spend time talking about creating hierarchies. Because I've talked about doing exposures, and are there any questions about doing exposures, though? I mean, do you get the general principle of how to do it? All right? Yeah. What? Yeah. This.
So I'm not sure if you'll get to it, but
Yeah.
I think we've been talking a lot about, like school refusal
Right.
and some specific phobias. But in terms of social phobia, when you do exposures, I find that a lot of times kids will say things like, oh, well, it's just working because you're here, or they're nice, and, that kind of thing. And I just find it really hard sometimes, like even when we go out into our university and they're talking to undergraduates, they're like, oh, well, these people
Well, what we
are
do is the
nice.
exposure is you have them talk to a group of people, and the group of people have to laugh at them.
Okay.
That's one of the things on the list. Okay. Now we're going to do it. Last week we had it where everybody was sitting there and they were like looking at you in a nice way. Today we're going to have some people looking very ambiguous, ambivalent. Or we're going to have some people who are actually even remember I said, being rude while you're talking. And then we might even have some people rolling their eyes at you. I mean, and they do it, and that's what they do.
So you literally stage that whole thing?
Oh yeah, totally. Not even 20, because we don't have that many kids, but we might have like 3-4 students in the.
What about the confidentiality in the school?
Well, this is a very good question. At FIU, everybody, is, they're part of the university, and they all have confidentiality.
So these are usually like undergrad RAs who
these
have
are
like
undergraduate RAs.
stuff.
Yeah. Well, I don't know. You guys tell me. What about in a public school? Are you?
I'm not gonna be like, hey.
Would you? I mean, I don't know. Would you really even be allowed to do this type of intense treatment in a public school? What's it? I mean, she's asking, because I said, like, I mean, because certainly with a lot of social anxiety, you do this kind of work, but how can you engage peers of the kids because of confidentiality? But, you know, I guess, I don't know, it can't, right? You can't. I guess you really, yeah. But I guess what you can do is that when it happens in the real classroom, if people were rude and negative, you process it with them and talk to them about it. Okay? You just talk about it with them with the cognitive work and process that. Right.